Reimbursement for Counselors, Advocacy, Updates, and Policy Implications with Dr. Matthew Fullen. As the webinar commences, you may type any questions you have for Dr. Fullen in the comment box, and they will be answered at the end of today's webinar. It is now my pleasure to introduce Dr. Fullen. Dr. Matthew Fullen is an assistant professor of counselor education at Virginia Tech. Dr. Fullen's research, teaching, and advocacy focus on the counseling needs of older adults, including the importance of Medicare reimbursement for licensed counselors. Dr. Fullen is currently co-chair of the ACA Public Policy and Legislation Committee and chair of the AADA Older Adults Task Force. As a scholar, Dr. Fullen's research on counseling older adults and Medicare reimbursement has been published in prestigious journals such as the Journal of Counseling and Development, Counselor Education and Supervision, and the Journal of Rural Mental Health. He is currently principal investigator or co-investigator on 3 grants, including a federal grant focused on suicide prevention in later life. Dr. Fullen's research on wellness with older adults has also been honored by the Mather Lifeways Institute on Aging with its Innovative Research in Aging Award. Dr. Fullen has published 17 peer-reviewed publications and more than 70 peer-reviewed conference presentations on various issues related to Medicare and adulthood. Before Dr. Fullen begins today, Dr. Christian Chan has a few announcements for everyone.
Good morning or good afternoon, everybody. We are so excited for you to join us here. Part of what I'm going to share as co-chair of the Professional Development Task Force is that in order to complete for some of the information for continuing education credit, so of course we need you to be registered. We need you to stay on for the entire webinar. We'll be keeping track, and we'll be sending out procedures for completion of an evaluation, and then we'll go ahead and send you a certificate for the hour that you spent with us learning here together. So without further ado, thank you all so much for joining us, and we will let Dr. Matt Fullen take us away here.
Thanks, Christian, and thanks, Janelle. It's a pleasure to spend this next hour with all of you. I'm excited to talk about a topic that is incredibly important, that continues to be something that the counseling profession works hard on, and will continue to be something that requires all of our collective energy and attention until we get this important legislation passed. So what I plan to do is to dive right in with a little bit of background about the Medicare program, but then really get into some of the findings that I and members of my research team have discovered in terms of the prevalence and impact of the Medicare mental health coverage gap. And then I do want to spend some time in the second half of our hour really talking about where the profession is at currently in terms of its advocacy on this issue. And this is actually a pretty timely webinar topic. We had put this on the schedule a couple of months ago, and there was actually a blast sent out by the American Counseling Association just yesterday and today, asking for ACA members and affiliated colleagues to do some very direct advocacy on this issue in regard to some of the COVID-19 stimulus packages that are coming, working their way through Congress. So that's a little bit of the outline for today, some background, some research, and then some updates on what we're doing right now. So without any further ado, what I'm going to do is share my screen with you all so that we can learn together. All right. So the Medicare program, as most of you probably know, is vast. It's the primary insurance provider for roughly 60 million Americans, and the number of people covered by Medicare is expected to continue to grow quite rapidly, which coincides with the demographic shifts that are occurring in the United States. And so we're expecting roughly 80 million Medicare beneficiaries by 2030. So this is a massive federal health program, a program that is essential for many older adults and people with long-term disabilities so that they might access healthcare. And this really is the primary access point for healthcare, including mental health, for people over age 65 and people who qualify due to long-term disability. The Medicare program is over 50 years old at this point, and it's something that was developed, over the course of the 20th century through a lot of compromise. And so the Medicare program was really intended to be the nation's sort of dipping its toe into something akin to a universal health care. And we continue to hear debates even now about universal health care and Medicare for all. Well, the Medicare program, even in its current state, was really intended to be this sort of first test run at, what does it look like to have a health insurance program that is largely run by the federal government, that will cover a swath of the American populace. And, over the course of decades of compromise, the current Medicare population, so people 65 and over, and people who qualify with long-term disabilities, were selected as the populations that would be covered. And so what we can see now is that has created some interesting dynamics for the counseling profession due to the slowness in the Medicare program updating some of its regulations. Currently, Medicare allows many other mental health professionals to be reimbursed, including psychiatrists, psychologists, clinical social workers, and psychiatric nurses. So there are Medicare mental health providers, and there are mental health benefits that are akin to psychotherapy that Medicare recipients can receive. So the types of services that counselors provide are covered by Medicare, but where there's a breakdown, and what we'll talk about today, is the license types that are covered under this program. Now, it's worth noting that the last time the mental health provider regulations were updated was in 1989 with passage of the Omnibus Budget Reconciliation Act. So in 1989, Congress decided to add clinical social workers as an eligible Medicare mental health provider group. And they also removed certain restrictions that psychologists had at that time. And so fast forward 30 plus years, psychologists, clinical social workers, and the occasional psychiatric nurse are the ones that you'll see providing outpatient or inpatient psychotherapy services. And then obviously psychiatrists are primarily involved under Medicare with medication management. Now, what's interesting is that in the 30 years since this update, the mental health marketplace has changed dramatically. Licensed professional counselors and licensed marriage and family therapists represent over 200,000 graduate level professionals. And this is roughly half of the national master's level provider workforce. So, roughly 200,000 LPCs and LMFTs. And then, that's about 50% of the master's level folks, implying that clinical social work and psychiatric nursing make up that other 200,000. I've also seen it cited recently that licensed professional counselors represent roughly 1/3 of the entire behavioral health workforce. And that is a citation that has come through the Health Resources and Service Administration. So all that to say, LPCs make up a big proportion of the mental health workforce. However, that wasn't necessarily the case back in 1989, the last time that Congress had concrete action on this issue. So one of the things that I've really tried to emphasize in terms of Medicare-related advocacy is to focus not so much on, why aren't we as counselors authorized now when we do very similar work, or we do work that we might feel is even superior in certain ways to eligible professionals. To me, the question is, what was happening in 1989? To what degree were different professions mobilized and synchronized to do really good advocacy in 1989? And to what degree have those circumstances shifted so that now, 31 years later, we're talking about an entirely different animal? The mental health needs of the population have increased rapidly due to the aging of the population. We have 10,000 baby boomers turning 65 every single day. that means there are far more people covered by Medicare and far more people covered by Medicare who may have an interest in using mental health services. So when I'm sitting down with a legislator and talking through this, I'm trying to highlight that what may have made sense in 1989 no longer makes sense in 2020. And in 2020, we have a growing problem on our hands, and that's the problem of Medicare recipients not being able to access mental health care at the time when they need it most. And the reason that they're having trouble with that access is because the Medicare program has not evolved to stay in touch with the mental health workforce. And so I like to talk about the need for a modernization of Medicare when it comes to its mental health provider regulations. So again, the focus less on, why don't we have the rights today, and more of a focus on, well, here's where we were at in 1989, here's how the field has evolved, here's how the needs of the Medicare population have evolved. Let's do something that's common sense today so that over the next 30 years, we can really make sure that this population's needs are met. So I want to share with you some research findings. There will be some findings from a quantitative survey that we conducted of ACA members, as well as some qualitative research that we've done through interviews with American Counseling Association members, professional counselors, as well as Medicare recipients themselves. So let's talk a little bit about the current impact of the Medicare coverage gap among members of the counseling profession. About 18 months ago, we surveyed over 6,000 ACA members to try to find out just how big of an issue is the Medicare coverage gap. Just how many ACA members are impacted by not being able to be reimbursed through Medicare. And in that 6,000 people, roughly, we had practicing counselors, we had students, we had counselor educators. And so I really want to focus in on what practicing counselors told us. And you can see that highlighted here. When we asked practicing counselors, which was roughly 3,800 people in this sample, have you been impacted by the Medicare coverage gap? Have you had to turn away a Medicare recipient because they wanted to work with you and you had to let them know, I'm sorry, I don't take Medicare? Or is there somebody that maybe you've worked with before, and then as they transitioned into Medicare due to age or due to disability, you had to let them know that you could no longer take their insurance and perhaps could no longer work with them? And then the other category that we were asking people about was whether they had adjusted their fees in any way, either by using a pro bono or sliding scale approach to try to make the Medicare issue somewhat palatable. And so as you can see here, when we used sort of these broad categories, we found that 7 out of 10, 70% of 3,800 counselors who talked to us said, yep, one of these things or multiple of these things has happened to me. I've had to turn someone away, or I've had to refer an existing client, or I've had to change my fees in order to make this work. Of that 70%, then we broke it down by category. Roughly half of ACA members that completed the survey who were practicing counselors had turned away a Medicare recipient. Roughly 39% had referred an existing client. And again, this might mean someone that you've worked with who then turns 65, becomes Medicare eligible, and all of a sudden shows up in your office saying, I have an insurance change and I'm on Medicare now. How's that going to work? We found that another roughly 40% of people that responded had either used a pro bono approach or some sort of sliding scale approach to make it work with their Medicare recipient clients. And so that might look like a person saying, you know what, the work I'm doing is too valuable with this person. I'm just gonna take it as a loss. I'm just gonna make sure that they can continue to work with me, and I'm gonna write it off and do pro bono work. We heard people that described that situation. We also have heard from people who will say, you know what, it doesn't make sense that somebody can't work with me just because they happen to be covered by Medicare, especially if I've already worked with them. So I'm going to work something out. We're going to work out some sort of agreement where we can reduce the fee, find something that's affordable so that we can continue this working relationship. So those are categories that we discuss, that we asked people about. And essentially what we took away from this is that the Medicare coverage gap is far more pervasive than we had even realized. We knew it was important, but we didn't realize just how many providers had been directly impacted by it. And then what we did was we took the same sort of data and we looked at it over the course of how experienced or how long people have been in the field. And essentially what you see is that the people that are relatively new to the field, they told us, it was somewhere between 40 and 55% of those early career, maybe pre-licensure professionals. But as the amount of time in the field increased, what we found was that these numbers just really elevated. And so by the time you've been in the field, 4 to 7, 8 to 15 years, we're really talking about the vast majority of professionals who have experienced the Medicare coverage gap. And to us, what we thought we were seeing here was just that, this is sort of a ticking time bomb that's out there. And if you're a professional seeing clients regularly over time, you're very likely to run into this. This isn't something that only impacts people who specialize in working with older adults. This is really an issue that can impact any professional counselor working in the field, particularly if they work in a community mental health or private practice setting, where you tend to have kind of a general part of the populace who come in using all sorts of different types of insurance trying to access your care. If you work in those settings, you're very likely to run into this Medicare coverage gap at some point. So then where we shifted within the survey was starting to ask for ACA members' perspectives on the impact of the Medicare coverage gap. And so not just prevalence, but we really wanted to understand, what's the qualitative kind of in-depth impact that this has on providers. And providers were telling us about the impact on their own livelihood, the impact on their practice, but they were also telling us about the impact on their clients and sort of their perceptions of how much negative impact this was having on Medicare recipients. So I'm going to share with you some quotes that help to kind of put this into context. So we had many people talk about how, in their view, the Medicare issue impacts the entire country, but it's particularly salient within certain areas. And rural areas were brought up as one region or one geographical segment of the population that's really impacted by the Medicare coverage gap. So this person said, I live in a rural area. We have a shortage of therapists, especially Medicare approved therapists, meaning psychologists, clinical social workers. And I have had clients who became very upset and even quit treatment when I was no longer allowed to see them. And this coincides with research that others have done outside of our profession, where people have talked about the fact that counselors comprise a larger proportion of the mental health workforce in rural areas, which can result in mental health access shortages. Another interview that comes to mind was with a provider who told us that she is one of a very short list of mental health providers in her rural community. And she had clients who, would come to her, begin working with her, and then they would discover, or, the clients would age into Medicare, or there would be some sort of status shift. And she would have to let them know, I'm sorry, I can't work with you anymore. And I really don't have anyone in the area to refer you to. The closest Medicare authorized provider might be 40 miles away, might be in the next county. And so in these rural communities, what we found was that the Medicare coverage gap just really creates this burden on Medicare recipients specifically, where there simply aren't other choices to be made. And because of these outdated policies, these Medicare recipients living in rural communities may go without care or may end up in precarious situations where they become hospitalized or have to access even more costly care because of the lack of counseling available in their community. We also heard from people who were really wrestling with the ethics of how do I maintain continuity of care when I can no longer work with this person from a reimbursement standpoint. So one person said, I've had to refer many clients to Medicare eligible providers despite the therapeutic relationship that has been established because Medicare limits who can be providers. And many of these individuals have stopped going altogether and are struggling with depression or end-of-life challenges without any help. And so again, you know, the research here really seems to corroborate what has been articulated in other parts of the literature. So, I mean, the irony is really quite thick here, but on one hand, we see a lot of the healthcare scholarly literature talking about the growing number of older adults, the growing numbers of the Medicare population, and the lack of mental health workforce available to meet those needs. And then on the other hand, we know that we have 200,000 roughly graduate level providers who are ready, willing, and able to meet those needs, and yet because of this outdated policy, can't do so. And so what you see in this quote is just some of the ways that people are wrestling with having to refer out clients who have done incredible work with them, and you know, not feeling good about that, not feeling good about having to cease a really thriving working relationship simply because of an insurance change. You know, another example of this is the unique hardship that certain populations face, and one of those is people who qualify for Medicare due to disability. So roughly 16% of the Medicare population is under 65, but qualifies for Medicare due to a long-term disability. And that can include a long-term psychiatric disability. So we've done interviews with providers, but also with clients who have told us about this really bizarre process of having a counselor that they've worked with, that they trust, that they're, you know, really having a pleasant experience with. And then the counselor is helping them complete paperwork to apply for disability. And once that disability paperwork is processed, there's a period of time that goes by, and then the client becomes Medicare eligible, which inadvertently makes them unable to continue working with the same provider that they've been working with for a while. So this person put it this way, you know, often clients would obtain disability benefits while I was working with them and would automatically receive Medicare, meaning that I suddenly was unable to continue meeting with them. It has a devastating effect on the clients, especially those who have persistent mental illness and have little control over their situations. And unfortunately, this part of the Medicare population is oftentimes overlooked, but is overrepresented in some of our data because people that qualify for Medicare due to disability are more likely to have a mental health concern than the rest of the Medicare population. And so it's more likely that these individuals will already be engaged with the mental health system and are more likely then to have already established a working relationship with a counselor, only to discover that as they qualify for disability and as they shift from SSI to SSDI, which then moves them into being Medicare eligible, that they have to then change their mental health provider. And like I was saying before, in some communities that's not possible because there may be a lack of these providers to begin with. So it's an incredibly messy situation. And you know, part of what's happening here is that Medicare and Medicaid are not coordinating very cleanly. So you have individuals who are on Medicaid, and in many states, counselors can be reimbursed through Medicaid. But then when they qualify for Medicare due to disability or due to something else related to age, they become kind of dually eligible, but Medicare is the primary payer. So Medicaid at the state level will no longer accept those benefits, kicks it to Medicare, which then rejects it because the provider is an LPC and not a clinical social worker or a psychologist. It's you wouldn't, if you were starting from scratch today and you were building out a coherent mental health system or a coherent healthcare system, this is not the way you would do it. And yet this is sort of what we've inherited through these artifacts of history and the way that Medicare and Medicaid have evolved in different ways. And it even is sort of a strange artifact of federalism and the fact that we have state-governed Medicaid systems and federally governed Medicare systems. And so it creates a problem where, you know, in spite of efforts that are being made to try to create more coherence across Medicaid and Medicare, when it comes to this mental health issue, a counselor might be covered by Medicaid in their state, do good work with a client, and then as soon as that client qualifies for Medicare, the working relationship is threatened. So that's a big problem. We also found in this data that, you know, ACA members, counselors really understand that this is a systemic issue. This is not just an issue about me as a provider and my practice. It's not just about my handful of clients who are impacted. This is something at the system level that is really not functioning the way it should. So this person talks about being one of the few agencies in their area who accepts clients who only have Medicare. But they say it's increasingly problematic because we can't find a social worker to work here. Okay, so they're looking for a Medicare eligible clinical social worker to have on their staff so that they can funnel Medicare clients to that one person. And there isn't a social worker to be found in their community. So they talk about having to refer out longtime clients due to not having the staff available, and having to refer out new clients for the same reason. When they do find a clinical social worker, that person might be booked out for weeks in advance for intakes because all the Medicare clients get routed to that person. And they talk about how LPCs not being recognized does a serious disservice to their population. And then they make a good note that, you know, it's the most underserved people who bear the brunt of this policy. They don't have enough access to providers, especially in rural and poor areas. So ACA members largely, like, they understand what's going on. Unfortunately, this issue also directly impacts counselors and counselor livelihood. So we heard from people talking about how, you know, in community mental health, it's incredibly heartbreaking when a client has to transition from Medicare to Medicare from Medicaid. And it's frustrating because many would benefit from continuing counseling and case management, but these services aren't available in the same way due to Medicare. It's kind of what we were discussing earlier about Medicare and Medicaid not communicating very coherently. Another person says, you know, having to explain to clients why Medicare won't pay me is difficult and almost embarrassing. Long-term clients reach 65, they present the most difficult challenge. Often these are people that cannot pay out of pocket, and so I have to make an ethical decision to refer or to go pro bono. I've done both of these and neither is satisfying. And then another person, you know, didn't mince any words. They said, I feel it's a disgrace to our profession and makes me embarrassed to be part of the profession in this regard. Many people who need assistance with their mental health or substance abuse cannot afford insurance and are on state aid, or they have to pay out of pocket. These are individuals we should be helping, not turning away. So you can tell that as we dug into more of these qualitative renderings of how this was impacting people, a lot of passion, a lot of emotion, a lot of frustration that counselors are experiencing. And one of the things that we've tried to do more recently is to triangulate these findings by interviewing Medicare recipients themselves. So we're still working on this analysis. It's not done yet, but what I want to share with you is just some emerging findings that we have. So we've been able to talk to 18 Medicare recipients, not a huge number, but really in-depth interviews with these 18 people to find out what do they think about what's going on. So what I'll share with you is that really there are primary trends or themes that are emerging. One is that many of these clients who actively are working with a counselor are incredibly thankful for the work that they're getting to do. They're incredibly grateful for how their counseling relationship is impacting them. And frankly, they don't see the need, or they don't really understand, why would I have to start over with someone else when the work I'm doing with this professional counselor is so valuable to me and so essential to me maintaining my mental health. They're sort of incredulous at times about, how is it that we talk about the importance of mental health care and I'm getting that help, and now all of a sudden, because of this insurance quirk, I'm not able to work with the person that I've invested a lot of time with. It just doesn't make any sense. They've also told us that in many cases, it's not easy to find providers who will take Medicare. Providers who will take Medicare, whether that includes clinical social workers or psychologists, sometimes those license types aren't available in a particular community. This person whose quote is up here, this is a Medicare recipient who said it's very frustrating. You get angry, despondent, even more depressed because you're already depressed. And then, you're trying to fight through your own issues just to get on the phone and find somebody. And then you find it so difficult to find somebody who takes Medicare. And some days you just want to give up. And if they allowed people who had an LPC to do counseling within Medicare, and they would be reimbursed for counseling, I think people in rural areas, it would be so much easier for them. And this woman lives in a rural area where, she was having to look about, in about a 2-hour radius to try to find a mental health provider who would take Medicare. Meanwhile, there are LPCs who work in her community who she could see tomorrow if Medicare updated its regulations. So this is sort of the injustice that we're dealing with. This is the way that it's directly impacting Medicare recipients. Another thing that I'll add is that this is not only a rural issue. It's really something that we're finding to be happening across the country, rural, urban, suburban. And the reason being that even if in your community there are, a higher proportion of clinical social workers or psychologists, it doesn't mean that they take Medicare. So it is possible for some of those providers to opt out. And it doesn't mean that they can see you in a timely fashion. So those providers may be out there, but you may be talking about a several-week wait until you can get in. Which again, when you're dealing with a mental health crisis, when you're dealing with something that you've been dealing, a chronic mental health condition, it's not something that, doesn't feel good to have to wait a month or longer when you know that there are very well qualified professionals who you could work with tomorrow if the policy itself, if the rules were updated to allow you to do so. And we're actually working on a little bit of a rough analysis right now of Psychology Today providers. So let me just tell you this, if you go to Psychology Today, which is a popular place to advertise if you're a private practice owner or an agency owner, and if you start to look at how many of those providers actually take Medicare, nationwide, it's about 1 out of 8. So about 12% of providers take Medicare, which means that if you have Medicare, you rely on Medicare to access mental health services, and you go looking for a provider and you search in your zip code, it's only about 1 in 8 people nationwide who are advertising that they'll take your insurance. And again, part of that is due to this Medicare coverage gap. If we added LPCs as well as LMFTs, that would change overnight. It's also a function of certain providers opting out of Medicare and being able to do so because the marketplace is sort of out of sync right now. And 1 out of 8 providers taking Medicare, that's not going to cut it, especially knowing that we have these growing numbers of people, 60 million now, but 80 million in the next 10 years, who rely on Medicare for their healthcare needs. All right, so I want to pause for a second and see if there's any questions before I dive into some Medicare advocacy highlights. And we will have more time at the end, hopefully, for questions, but I'm just going to pause for a second to take a sip of water here. All right, well, hearing none, we will continue and have some more time for questions at the end. So what's going on in terms of advocacy on this issue? Let me bring this back up here. All right. So in terms of Medicare advocacy, as I was saying before, the impact of current Medicare policy on clients and on the profession, more pervasive than we realized. It's impacting a diverse range of people, older adults, people with disabilities, but there's these other populations represented within that. So disabled veterans oftentimes end up on Medicare. People who qualify due to mental health concerns, who become Medicare eligible because of a psychiatric disability. People who are affected by the opioid crisis, people living in rural communities. These are all subpopulations that we know are particularly vulnerable when it comes to mental health care. We know that there's a national dialogue about how to improve access to services for these populations. And so as we do advocacy, we try to make a connection between the issue that we are representing, which is the need for counselors to be added to Medicare, and the way that that aligns with some of these other national strategies, national goals. So when I'm thinking about Medicare advocacy, I'm trying to align it with these populations here on the screen. How would adding counselors to Medicare improve things related to the opioid crisis? How would it improve the ability of people in rural communities to access care? Part of what has to happen for us to be successful with this issue is to create a broad enough coalition of lawmakers and constituencies who are going to have very different priorities. So there are going to be some lawmakers who represent rural constituents who want to talk about the impact of not having enough mental health care in rural communities and how we've been impacted by opioids and things of that nature. And so I need to have talking points ready to go related to that issue, while I'm also talking about the importance of veterans having access to mental health care. And we know that that is a perpetual issue that the federal government attends to. So it's important to be somewhat nimble when you're thinking about advocacy and to be able to articulate the way that this impacts different constituencies, and then identify what are the constituencies that my lawmaker is really keen to, and throw the book at that particular issue. Where I want to go here is to talk a bit about some advocacy recommendations, in addition to some updates on where we are at as a profession on this. So, one recommendation that I've been promoting for a couple of years now is that we really need to frame this problem as a lack of access to needed services rather than as a professional equity issue. So when I started working on this maybe 6 or 7 years ago, many of the talking points that I heard focused on how counselors have similar training to everyone else covered by Medicare, and how it's not fair that we're left out of the mix when clinical social workers or psychologists are allowed to be reimbursed by Medicare. And while I agree with that fact, that isn't the sort of thing that moves the needle with lawmakers. Lawmakers need to understand how the current policy is interfering with people in their districts accessing services. And so I think it's important for us to emphasize that this isn't about us getting a bigger piece of the pie. This is about Medicare covered clients and patients having the same access to mental health care that everybody else does. And that leads to the second point. The second point that's really important to emphasize, Medicare is the only remaining insurer that excludes LPCs. So TRICARE, the VA, Medicaid, private insurance, all of these other bodies recognize that LPCs are a major part of the mental health workforce and need to be recognized as such. I know there are state variations. We can talk about state by state variants when it comes to Medicaid or private insurance. But the point is that nationwide, all of these other programs say yes to LPCs. Medicare is the only one that currently says no to LPCs. Why is that? Is it because the Medicare regulations haven't been updated in over 30 years? And that the needs of the United States Medicare population are far more vast now than they were in 1989? Is it possible that it's because the counseling profession has come together and positioned itself in a way that hadn't fully been actualized in 1989? So to me, when we're talking about this issue with lawmakers, it's important to sort of put the pressure on the Medicare program to keep up with everyone else, to keep up with what's happening in the private insurance industry, where they want to open things up to any sort of graduate level provider who's well qualified, who will do good care as a means of managing, the healthcare workforce. So when I'm talking about this, I want to put the onus of responsibility on Medicare and on Congress that sort of regulates Medicare to think about, is Medicare today doing what it's intended to do when it comes to mental health services for older adults and people with disabilities? And I think then we can argue that based on the data that I've shared with you thus far, the answer is no, it's not doing its job. And so it requires a modernization. We need to modernize Medicare so that it reflects the current state of the American mental health system. And so a good anecdote for this to me is that, if you were to go to the local community mental health agency in your area and ask them which license types do you hire to meet the mental health needs of people in your community, I'm willing to bet you that LPCs are included in that list and might even make up roughly a third to 50% or more of the providers in your local agency. So to me, that represents the state of current affairs within the current mental health system. LPCs are working in those contexts. So if I have Medicare and I want to use my Medicare to go access counseling, and I go to my local community agency, and they don't have anyone on staff that takes my insurance, that's a problem. And that's a problem that shows disconnect between Medicare's current regulations and how the mental health workforce currently operates. So you can tell, when I'm talking about this with lawmakers, I'm really trying to emphasize the mismatch, that things have changed in 30 years, that they need to dust off the Medicare provider regulations when it comes to mental health and take a fresh look at this. I have no doubt that if they take a fresh look at this, they'll see that professional counselors are every bit as qualified, every bit as integrated into our communities, and would make the right decision. But they need to be able to think about it that way, as opposed to us leading with, hey, it's not fair that you don't recognize our license. And I come bearing some good news, I think, which is that over the last couple of years, I think we have really hit a new high watermark in terms of how professional and coordinated the Medicare advocacy has been. So a few talking points here. I would say that Medicare reimbursement for counselors is right now the top ACA advocacy issue, like the most highly prioritized issue. I think it'll probably stay at the top until it passes, whenever that might be. ACA is working with a Medicare mental health coalition that includes the Marriage and Family Therapist Association, National Board for Certified Counselors, other professional trade organizations that are connected around this issue. So to me, that's a sign of progress. We're not trying to just have ACA do this and then have NPCC do this in some other vacuum. Trying to get away from silos and all have a united voice on this. The National Council for Behavioral Health is a pretty well-regarded, public sort of trade organization that represents behavioral health care. It's not affiliated with any one profession. And they have adopted Medicare reimbursement for counselors and LMFTs as one of their maybe top 3 to 5 issues. And at their most recent Hill Day in 2019, if you look at the paper, look at some of the glossies that they were handing out, adding counselors to Medicare was right there in that list of 3 to 5 things. That's a big victory for us. Another recent change that's really exciting is that through direct advocacy to the Center for Medicare and Medicaid Services, which is the bureaucratic wing of Medicare, they're the ones that actually manage the program, and through the Support Act, which was a major legislative package that was intended to help address the opioid crisis, CMS had this little, you would blink and miss it, but it's this little bit of language that when they're defining which types of providers can bill Medicare when providing services in an opioid treatment program, counselors should be included within that group. So I've got good news and bad news. The bad news is that's a very small fraction of ACA members who are working for an opioid treatment program. These are very formal programs that offer bundled opioid treatment packages. They have to have medication assisted treatment as well as therapy. So this isn't the sort of thing that overnight is going to make a huge number of ACA members eligible for Medicare unless you do work for an opioid treatment program. But what it does is it puts language on the record that CMS is saying that within this very, very specific context, Medicare dollars can be spent on what counselors do. And that's not just a symbolic victory. The way that helps us to really build the case longer term, because it shows you that clearly there's no sort of issue in terms of professional credibility, because CMS is saying we'll spend dollars for the care that counselors are providing. It also means that people who have this particular diagnosis with an opioid use disorder have access to that sort of care. It sets a precedent that we can then point back to when we're trying to get more things done. And that's not a small change. I mean, that's a significant thing that directly came out of some advocacy work from last fall. Another exciting thing is just we're starting to see some references to the Medicare coverage gap in the national media. This was about a week and a half ago. I opened up Politico, which is a mainstream sort of politics website, politics magazine, and they had an article about telemental health. And in that article, Lynn Lindy from ACA is quoted. And as I kept reading, I saw a paragraph talking about the Medicare coverage gap. I'm going to share that paragraph with you here in a moment, but it was exciting because when we start to see the media validate that this is really a problem, this isn't just some sort of territory issue for counselors. This is an issue that's impacting Medicare recipients who can't access care at the time that they need it. That's a big win. And that, Politico is something that lawmakers read, lawmakers and their staff read. So it's important that we get the word out through those sorts of channels as well. And then, when you think about kind of the more traditional advocacy, we've got 2 bills that have been in Congress now, roughly 16 months. Senate Bill 286 has 30 co-sponsors. House Bill 945 has 113 co-sponsors. These are both bipartisan bills. What we're starting to see then is this coordinated effort where we have legislation, bipartisan legislation with a lot of support growing, these references in the national media, advocacy within CMS directly, creating a coalition more broadly. All of these things have to happen in concert for us to be able to do the sort of push that I want to talk to you right now about. I'll come back to that in a moment. So the current push is trying to create an advocacy strategy connected to COVID-19 stimulus package. And what I'll say is, Congress right now is spending money, understatement, to try to address the impact of the coronavirus. And we all know there's a ton of different issues that are being impacted. What hasn't yet made its way into these packages to the degree that it should is mental health. And those of us who are mental health providers understand that the pandemic is not only going to impact people's physical health care, but this is going to have a huge consequence on mental health, both now and into, the next few years to come, at least. So we're trying to position take all of the work that we've already done and try to identify how we might have our bills considered as part of a COVID-19 stimulus package, so that whenever Congress decides, we should do something related to the Medicare population, or we should do something related to mental health, we want to already be at the table ready to say, hey, Congress, we've got this issue. We've already done some of our research on it. We've already got co-sponsors. This is something that already has momentum. Here's why it matters. Here's how it's going to impact older adults and people with disabilities. Would you consider integrating this into a larger package that you might pass? So that's the current strategy. And that strategy really requires having all of these other things in place. You can't start from scratch today and come to Congress and say, hey, I've got an idea for your stimulus money. You have to already be pretty well ramped up with that. So what we're asking people to do is a couple of different things. So one, there is a voter voice campaign that is on the ACA website. I've provided a tiny URL that you can use to get to that. And basically through that voter voice campaign, you can send a simple message that will go to the House Ways and Means Committee, the Senate Finance Committee, and the director of CMS. And each of those are very strategic places where we want to make this communication, because we want, an ideal situation would be for the Senate Finance Committee and the House Ways and Means Committee to have a robust conversation about whether or not our bill makes sense when they're ready to do something on mental health related to COVID-19. That's kind of the angle that we're going for here, is we want Congress to be able to say, we should do something about mental health. There's a whole host of things we should do. We've got this issue about Medicare not adequately covering older adults and people with disabilities. Let's talk about whether that has some merits that we might want to consider. ACA is also trying to solicit short videos that could be posted on social media, including Twitter. And what they're asking is for people who are interested to do that and to tag all of these Twitter accounts. And these happen to be the chairs of the Ways and Means Committee, the Senate Finance Committee, and then House Speaker Pelosi. And so the idea being that we really use this as an opportunity to educate these individuals about what counselors do, why the Medicare coverage gap has been so problematic for our clients, so that when they're sitting down and talking about these issues, we're representing our profession, and we have a voice at the table. So here's the last thing I want to share that kind of coincides with what we were talking about before. You can see on the right-hand side, this is the 2020 ACA public policy agenda. So top federal priority is secure Medicare reimbursement for licensed professional counselors. This is available from the ACA website. You can see the Politico headline that I was talking about. You can check that article out. An interesting reference to the Medicare coverage gap. You can see a picture of some of my counseling students who went to DC during the National Council Hill Day, and who have also developed a Facebook social media campaign regarding the Medicare coverage gap, and that's what the little logo in the middle is. And then you can see the logo from the Medicare Mental Health Workforce Coalition and all of the different organizations that are involved there. Now, we'll make sure that these slides are available. I know we're running out of time. I do want to put a couple of these resources up here on the screen, and then I plan to use just the last few minutes to field any questions that people might have. And yet again, we'll make sure that these slides get out to everybody. All right, so a couple of questions. Let's see here. Okay, so the MCA wants to advertise that the National Council Hill Day for 2020, which I referenced the 2019 event, the 2020 event is June 23rd and 24th. It may be in person, it may be a virtual Hill Day. Either way, it's a great event. And this is a way to really have an impact on our profession, because this is an event that is attended by behavioral health advocates across all the professions. I'll share this as just kind of an anecdote. When the National Council created its glossy to hand out to lawmakers, every single sponsoring organization had a logo on that glossy. And one of those glossies said, Medicare reimbursement for counselors and LMFTs, this is essential, here's why we need it. We want your legislative support. And it didn't just have ACA's logo on it, it had every one of those 20 sponsoring organizations' logos on the glossy handout. Even the National Association for Social Workers, because they're a supporter of the National Council for Behavioral Health. So my point being that these cross-disciplinary advocacy opportunities are incredibly important because they get Congress's eye, and they also allow other people to help make the case for why this matters. Brad asks, how can we better engage the national media for supporting this cause, especially considering the potential COVID-19 and economic crisis we are facing today? I think that's a great question. I would love to connect offline if there's anything in particular that you want to give thought to. I think this is a time for some op-eds to your local paper. I think this is a time for, if you have any sort of blog or social media or other thing where you have an audience, to use that audience to very matter-of-factly talk about the Medicare coverage gap and how you're concerned that the Medicare populations will be overlooked when we start to think about the mental health consequences of COVID-19. We're going to have a national conversation at some point about mental health. My fear is that older adults and people with disabilities, the populations covered by Medicare, will not be the ones who are adequately talked about, even though we could make the case that those populations are even more impacted by things like social distancing and some of the other COVID-19 consequences. So I think it's important for us to highlight that issue and then very matter-of-factly talk about the Medicare coverage gap and just how problematic it is. If there's any other questions, please feel free to reach out to me. I can be contacted at mfullen@vt.edu. I'm also getting ready to record my Twitter advocacy video right after this call and try to send it out there so that all of those legislators can hear about why this issue matters and why House Bill 945 should be a part of Congress's stimulus package whenever they decide to do something about mental health. Thank you all for your time and your attention to this cause.
Thank you so much, Dr. Fullen. That was a wonderful presentation. Also, thank you everyone for attending today. Within a few days of this webinar, you will receive an evaluation link that should be completed, and then you will receive your CE certificates via email. Thank you again, everyone, for attending, and have a wonderful rest of your day.